Hodgkin's lymphoma is a cancer which develops from our lymphatic system. We all have lymphocytes in our circulation. We all have lymph nodes. And this is a tumor which primarily develops in the lymph nodes. Now, depending on the stage, it can involve other organs too. But the lymph node grows abnormally because of proliferation of what we call the Reed-Sternberg cell. Both Hodgkin's and non-Hodgkin's lymphoma are under the broad category of lymphoma, and they look different under the microscope. While in Hodgkin's lymphoma, the characteristic malignant cell is called a Reed-Sternberg cell, and they're quite hard to find when you look under the microscope. In non-Hodgkin's lymphoma, which can be B cell or T cell, it's much easier to find the malignant cell, and often sheets and sheets of them. So while they're both lymphomas, they look completely different under the microscope, they behave differently, and we treat them differently. Hodgkin's lymphoma is a disease which has two age groups predominantly. One is the younger age group between 18 and 30, and then we see a second peak after age 60. The most common presentation is patients reporting a swelling which they've noted incidentally, which is painless, either in the neck or the armpit. Often, if they have a big mass around the heart, they can get short of breath, they can get fevers, have some weight loss, and sometimes they present with just itching all over the body for several months before the diagnosis is made. The symptoms basically depend on where the lymph nodes are present. And most of them, about 60–70% of the patients, present with disease above the diaphragm. So noticing lymph nodes, as I said, in the neck or the armpit, or then symptoms from compression of the organs in the chest are the predominant symptoms they present with. So for diagnosis, we need a biopsy. Often, initially, patients get an FNA, which doesn't really give us an answer because you can't really see the architecture of the lymph node, or as I said earlier, the malignant cell is pretty rare. So you really need a good biopsy, and at the very minimum, a core biopsy. Once that is done, the pathologist can do special markers and look under the microscope, and Hodgkin's has a particular phenotype which is picked up on immunohistochemistry, and that's diagnosed. Once the diagnosis is made, there are, of course, some laboratory tests we do to sort of help us prognosticate it a little further, but at the fundamental level, we need a biopsy. For prognosis, it varies between early and advanced stage, and for early stage, most of the treatment regimens are based on whether we define the early stage as being favorable or unfavorable. And the typical unfavorable characteristics we look at are, does somebody have B symptoms, which are like fevers, weight loss, night sweats? Is something very bulky? Is there a mass of nodes which is more than 10 centimeters? Or is the patient very sick from the disease, advanced stage disease? For advanced stage, we look at something called International Prognostic Score, which looks at 7 factors. And of course, if you have all 7, it's the highest risk disease. So, and it's divided into low risk, intermediate risk, and high risk based on the presence of these factors, being male, having stage 4 disease, age over 45, a hemoglobin less than 10.5, a white count more than 15,000, or having an absolute lymphocyte count of less than 600 or 8%, as well as an albumin of less than 4. And we kind of look at these clinical factors to help us decide who are the patients with the worst prognosis, and then try to use more aggressive approaches in these patients. One, it's highly curable. And in over 90% of patients, whether they have early stage or advanced stage disease, it's highly curable. The crux of the treatment is chemotherapy dependent. And depending on whether it's early stage or advanced stage, the number of cycles can vary. For early stage, sometimes radiotherapy is also incorporated, but it's primarily chemotherapy based. Now, for early stage, the most common chemotherapy used is ABVD. And again, the number of cycles vary, and whether we add radiation varies on risk factors. For advanced stage disease, the standard of care has actually changed. It's no longer just ABVD, it's adding novel therapies to ABVD. And most recently, there was a big phase 3 trial done in the US, which has changed the standard of care, and it's adding a checkpoint inhibitor called nivolumab to AVD chemotherapy, which results in almost 90% cure rates or more There's another regimen developed in Europe called BRICAD, which uses brentuximab in another backbone of chemotherapy, which also has excellent results. So I would say that for advanced Hodgkin's disease, Nivo, AVD, or BRICAD are the standard of care. And for early stage, it's ABVD with or without some radiation. So in the relapsed refractory setting, the standard of care is to give a salvage regimen, get the patient into remission, and then take them to what we call an autologous stem cell transplant, which is a bone marrow transplant, but using your own bone marrow. So the options, the newer things in that which we do now is using regimens which optimize the chances of patients achieving a remission. And we've learned that adding a checkpoint inhibitor to a salvage regimen increases the complete remission rate and actually improves the outcomes after transplant. There are regimens which are now looking at avoiding transplant completely if the relapse is very limited. But again, all that is quite experimental. As of now, the standard is a salvage regimen, ideally using a checkpoint inhibitor. If patients have had a checkpoint inhibitor, then using a brentuximab-based regimen and taking them to transplant. So the biggest advances in the last decade were the development of brentuximab and the checkpoint inhibitors, which have frankly revolutionized how we treat Hodgkin's in the frontline and the relapse setting. Beyond this, there are newer generations of these antibodies being developed. There's also some efforts which are being evaluated developing a CAR T for Hodgkin's, which has been very successful in the non-Hodgkin's lymphoma space. But this is targeting CD30, which is the hallmark of a Hodgkin cell. Again, it's a little premature to move any of those into the frontline setting because they're all in the clinical trial stage. There are studies going on looking at targeting the microenvironment in addition to targeting the Reed-Sternberg cell. But again, a lot of this is fairly preliminary.